Hello, good people. As promised, here comes our lecture about analgesia in the veterinary patient. So buckle up and bear with me. If I can get it to advance. Oh my goodness. There we go. Analgesia. Easy peasy in terms of terminology. Analgesia is relief of pain. For a long time in our profession, the idea and the notion that animals required pain relief was really under-addressed. When I graduated in 2000, there were still practitioners out there that wouldn't give companion animals pain medications like after a broken leg or a splinting or surgery because they didn't want them to move around. So that's not too far out of reach. Obviously, our patients cannot tell us that they're hurting, and that doesn't mean that we ignore the fact that they very well may be in pain. And in order to do that effectively, we monitor certain parameters. So pain really and truly should be considered a fourth vital sign overall. And today we're going to talk about pain, the physiologic process of pain, the way that we evaluate pain in our veterinary patients, and also some of the medications that we use to treat pain. So pain receptors, if we're going back to our neuro chapter in A&P, pain receptors, remember, are called nociceptors. They are everywhere in the body. They are not actually present in the brain. So if your head were to be cut open and a neurosurgeon is doing surgery on your brain, you don't actually have any sensation in the brain with respect to pain. Pain receptors vary dramatically too. You can have very, very simple nerve endings to very, very specialized structures that detect mechanical forces or temperature or those sorts of things. The overall goal of pain detection is to protect the body from any type of damage. And I hope you remember this from A&P as well. We have four basic processes of pain. We have transduction, in which the nerve impulse is generated at the source of pain. We have transmission that goes up along peripheral nerves, travels to the spinal cord from the nerve. The spinal cord then modulates that pain. So it can change the intensity of how the brain perceives that pain, depending on different stimuli and sometimes depending on pathology as well. And then true perception of pain occurs in the brain. That is our interpretation, or any animal's interpretation of pain. Pain can also be classified in a lot of different ways. You can have superficial pain that is on the surface. You can have deeper pain, which reflects muscles or joints. You can have visceral pain as well. That is organ pain. Oftentimes we refer to non-organ pain, particularly with respect to the muscles and joints. We call that somatic pain. Pain can also be acute or it can be chronic. And acute pain is usually more sharp and intense, whereas chronic pain is more dull and aching pain. When it comes to analgesia, which is pain relief, the goal of analgesia is to target specific receptors. Ideally, we like to hit receptors at two or more different places, or hit it along different parts of that transmission, transduction, modulation, perception path. When we do this and we combine different types of analgesics to treat pain, we call it multimodal analgesia, a lot like multimodal anesthesia, or using multiple drugs to achieve quality effects and lessen potential adverse effects. Likewise, with pain relief, we call it multimodal analgesia. And multiple effects, multiple different receptors, allowing us to use lower doses of each drug in order to hopefully maximize the benefits and minimize the side effects. All right, more terminology. I know this is terminology heavy, but we're never going to be done learning terminology in the course of your education. Physiologic pain is pain that is described as adaptive pain. So it's quote unquote good pain that helps to promote survival, and is generally treatable pain, and it typically resolves once the painful stimulus is removed or once the body has healed from the insult. Now, pathologic pain is different. Pathologic pain is intense, persistent, what is considered to be maladaptive pain. Something is not right along that pain pathway within the nervous system, and the pain that is present serves no useful function. Some of you may have some chronic pain issues. Most significant, like nebulous chronic pain issues can be pathologic in origin or pathologic pain. Inflammatory pain, very specifically, is pain that is occurring at the site of tissue injury due to the release of chemical mediators and activation of the inflammatory cascade. Two of the big indicators with those chemical mediators with inflammatory pain are prostaglandins and histamine. Then we have what's called neuropathic pain, which neuropathic pain is much more specific, and it is specific pain that originates from an injury to a nerve rather than epithelial tissue or muscle tissue or connective tissue, if we cannot find another source for it. So sometimes idiopathic pain is referred to as neuropathic pain. Acute has immediate onset and resolves after healing. Chronic is weeks, months, years, and persists. This is an important one. It persists after healing. Visceral pain is, again, organ pain, somatic pain, bone, joints, muscles, skin, everywhere else in the body but the organs. All right. Why do we treat pain? Well, you and I know that pain is, while it can be protective, it is generally unpleasant. And chronic pain promotes what we call a catabolic state, which is an excessive, accelerated metabolic state, which can ultimately lead to muscle and tissue wasting. Untreated pain also has the effect of suppressing the immune response, promoting inflammation, which delays healing, and it increases our anesthetic risks. That means we need more drugs to treat really painful patients. And in general, like, pain is equal to suffering. Not all suffering is pain, but all pain is suffering. And generally, we want to try to avoid this for our patients as well as our clients who own them. Chronic stimulation of those pain receptors, those nociceptors, it can, in fact, result in those receptors being overly sensitive. So it requires a less painful stimulus to produce that same painful response. Another couple important terms. One is called primary hyperalgesia. So primary excessive pain, essentially. A local or peripheral area is more sensitive to further insult. And then we have, and that is usually, again, that's usually at the tissue level, primary hyperalgesia, where something is injured and then it hurts to the touch. You touch it again, that's even more painful, like a bruise or a sprain. Whereas secondary hyperalgesia actually occurs in the central nervous system from chronic peripheral nociception. And we have a special term for secondary hyperalgesia, which we call wind-up pain. And animals that have wind-up pain are usually animals that have chronic pain issues. Most commonly, I would tell you that I have seen wind-up pain in animals that have chronic intervertebral disc disease, like we talked about in companion. With specifically wind-up pain, we believe that a specific type of receptor called the NMDA receptors, which are what ketamine works on, are implicated in wind-up pain. And so we're starting to use low doses of some of these NMDA antagonists like ketamine to help block some of these pain receptors and can be helpful in chronic pain management for our patients. All right, untreated pain increases cortisol, stress hormone produced by the adrenal glands, increases norepinephrine and epinephrine, stress hormones produced also by the adrenal glands. Cortisol is produced in the adrenal cortex. Norepinephrine and epinephrine are produced in the adrenal medulla. Increased cortisol is an antagonist of insulin production. So ultimately we end up having decreased insulin production. So the glucose can't get into the cells and the cells can't grow. Thus, they shrink, and we get this chronic catabolic state that results in muscle wasting and loss of general overall body weight. Pain will also increase the sympathetic nervous system stimulation. So it'll cause a painful animal is a more anxious animal. I think hopefully you guys have all seen that at this point in time. But that sympathetic nervous system stimulation is not great, particularly if we want to go into surgery and induce anesthesia. That sympathetic nervous system increases cardiac workload. It causes vasoconstriction, all of which we are immediately going to tank as soon as we put anesthetics on board. Distress is defined as behavioral manifestations of pain. And with respect to interpreting pain in our patients, it's really, really important to understand that every animal is an individual. And we will have some patients that are incredibly stoic. I think cattle, like as a species, cattle are very, very stoic creatures, whereas some horses may not be as stoic. Likewise, we have things like stoic breeds of dogs, things like, oh, what's a stoic breed? I mean, a lot of Labradors are pretty darn stoic, whereas a lot of Chihuahuas are not very stoic. And they're often more likely sometimes to be stoic or hide their behavioral manifestations of pain in our presence because they're stimulated, they're stressed, they're thinking about other things other than where they're hurting. So a lot of times animals that have pain, by the time they get to our hospitals for evaluation, if it's not like horrible pain, they may mask it in our presence. So it's really important that we listen to clients when they tell us they believe that their animal is in pain. Assessing pain is a really important part of your job as technicians. It applies to every patient for every reason, and not just surgery patients or trauma patients. Our patients can't talk. So what types of parameters might you think we can utilize to assess pain? To an extent, our pain assessments do have a degree of subjectivity as well as objectivity. And when I say that, what I mean is that you must practice pain scale scoring and looking for these signs of pain, because we base them on not only behavior, but also vital parameters as well as physical exam findings. So in people, we have a very simple question that we ask humans is, how would you tell us rate your pain on a 0 to 10 scale? And you can put it on 0 to 10. Of course, our patients can't do that. So alternatively, what we have adapted in veterinary medicine are the use of different pain scales. And we use here at Crowder, we use the Colorado State University Canine and Feline Acute Pain Scales. It ultimately gives a 0 to 4 numeric scale in multiple categories. Down below, you'll find the Glasgow Composite Measure Pain Scale and the UNSEP Butukatu multidimensional composite pain scale for cats. And it is really, really complex. There are examples of these in your anesthesia and analgesia textbooks. They're great to know, but in terms of must know, you must know the Colorado State pain scale inside and out. I would encourage you to recognize the names of other pain scales that are widely used in veterinary medicine, like these below. And for surgical inpatients, this I want to stress as we're getting into surgery labs. It is incredibly important, if you are caring for them, that you have an understanding of what their baseline behavior looks like before they are in the postoperative state. So you've got to take a look at your patient, assess them before surgery as well as after surgery. And there's a lot of variability. One animal may scream bloody murder and you don't even touch it. Another one may sit there stoically while you palpate an obviously fractured limb. It is really, really broad how different animals respond. It's also important to watch that patient when possible outside the presence of people, because some pets may be even more reactive when you're handling them in the absence of pain, while some dogs are so happy to see people that they may just forget all about it and pretend like they're not hurting so that they can interact with you. And I know you guys have all seen pets that are both incredibly scared. We happen to have some in our kennels right now, as well as some incredibly friendly animals. All right, so some easy signs of pain. Limping or lameness is a big one. I'm going to move my little head down here. Whining, circling, the ability to lay down or get comfortable. Dogs in particular may adopt this position that we call the praying position or downward dog. This is often a fairly reliable indicator of abdominal pain. And I get worried when I see a dog that repeatedly postures to do this that isn't obviously playing, because dogs can play bow like this too. But outside of play bowing, this is a pretty consistent, repeatable sign of abdominal pain for dogs. Now, cats are trickier because cats are weird. Cats may have this grimace. This cat is doing a pretty good job of grimacing. They may also loaf themselves or pull all 4 feet up underneath their body and not pay any attention to their surroundings. A lot of times they're in the back of the cage. Sometimes they're even facing the back of the cage. They just don't want to be touched. They don't want to be messed with. More difficult signs. There are some cats, because, cats are weird. Some cats will purr when they are painful. It's bizarre, but it does happen. Now, assessing lameness in a cat. Let's think about that. What do we do with dogs? We put them on a leash. We walk them around an exam room. Most cats you put a leash on and they're not going to walk. They're going to flop to the ground or they're going to panic. So a good way to assess for the presence of lameness in cats is if you have a small empty room where a cat cannot hide from you or get under anything, like in our kennels, that space above the kennels. Allow them to move around in an empty exam room and watch them move, because they won't move when we want them to, like a lot of dogs do. Sometimes inappetence or not eating can be pain related, and that can be either somatic pain or visceral pain. It could also be related to GI disease or anxiety. It is incredibly important that as a technician, you get good history questions answered about what an animal's baseline behavior is like. Are they uninterested in you? How are they with respect to the clients? How do the clients think they are? There are a lot of people who still don't believe that animals are in pain when they very clearly are. And you also have the opposite. You have a dog or a cat that you're having a hard time finding a pain sign on, and the client is pretty adamant that they're painful. So we need to look really hard when clients are telling us that they're painful and we're not finding it. We also need to do a very good job of educating for the clients that are telling you that their dog isn't painful when they very clearly are. So, is always, and this is really important, not just with pain, but also with disease symptoms. It's always important to remember that the client knows their pet better than we do. And so even if I can't find anything specific on a physical exam, or if we do a bunch of intake testing, if we run CBC chemistry, we get some x-rays, we do an ultrasound, we're still not finding anything, I tend to always err on the side of believing the client, unless the client is absolutely crazy and obviously crazy. And some people can be difficult, but most people aren't obviously crazy. And so a lot of times those are difficult situations to deal with. And we do have to take a watch and wait, or we treat presumptively for pain in those situations. The back side of this slide is just the visual representation of the Colorado State pain scales. These are hanging in our treatment area. They're also in your book. Remember, please, that this is the one that we use here at school and is the one that you guys are expected to understand and be able to use. All right, this is an instance of the Glasgow Composite Pain Scale. I just put it up there for you to see it and to be able to recognize it, but it is kind of interesting to look through these different scalings and see how each work. This one is generally a pretty good. It's actually a study of this UNESP Butukatu scale. And this is a study of how well it seems to work comparatively. And the general consensus is that none of these scales are perfect, but in all, they are a very, very useful tool for us in veterinary medicine. All right, so when do we address pain? Perioperative, that means before the painful stimulus. So perioperative or preoperatively, we do that with pre-meds, we do that with multimodal analgesia, and we do that by treating the pain before it occurs, and then 100% post-operatively. Multimodal is often optimal, but it is really dependent on the origin of the pain, the severity of the pain, and the type of pain that is expected. And please keep in mind that some surgeries are a lot more painful than others. Bone surgery, severe musculoskeletal surgery. You will never find more painful animals than like dog-on-dog violence. Those are some horrible injuries, and you guys understand the different mechanisms that cause it, and the pain that those things create is incredible. Now, let's talk about pharmacology of analgesia. We have a bunch of different options, and I have listed them all here for you. Number 1 is opioids. Number 2 is non-steroidal anti-inflammatories. 3, local anesthetics. 2, alpha-2 adrenergic agonists. 4, 5, ketamine, tramadol, adjunctive use of tranquilizers with analgesics. So things like neuroleptalgia, which is specifically tranquilizers plus opiates. Gabapentin, amantadine, corticosteroids, all of these drugs individually and in conjunction with each other we use to treat pain. Let me also remind you, please, 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 if you are not making your own drug chart, you need to be doing that. Again, more drugs are coming, more drugs are coming, more drugs are coming. It is important that you do not fall behind on learning these drugs. We're going to start with the opioids. Opioids, what do? They inhibit perception of pain in the brain. They also inhibit central sensitization toward pain in the spinal cord. So opioids are very, very effective analgesic drugs. They work on multiple different pain receptors. The big ones to know are mu and kappa. Drugs that are opioids that are pure mu agonists are considered optimal for moderate to severe pain. Now, we have several different classifications of opioids. We have pure mu agonists. We also have partial agonists, antagonists, and partial agonists. So they get confusing really quickly. It is really important that you understand them, though, because we do use a lot of them in veterinary medicine. Now, of the pure mu agonists, and let me say this, most of our pure mu agonists are Schedule 2 drugs, Schedule 2 down here. So they have a highest potential for abuse. Morphine is one of the oldest opioids. It binds mu and kappa receptors. It treats both visceral and somatic pain. Now, important thing to know about morphine is that if you rapidly inject it IV, it will cause the release of histamine from mast cells. Histamine will cause vasodilation. It will cause flushing or redness of the tissues. It will also cause itching, and drum roll, it will also cause nausea. And a lot of times it will cause them to poop as well. So be prepared for that when you use morphine. If you give it slowly IV, it slows down this big histamine release. So any morphine injection should be given IV slowly. Now, one of the major side effects, expected side effects of opiates is this right here. Respiratory depression. That is the major side effect that you need to know that is associated with all of the opioids, is the potential for respiratory depression. All right, other pure mus. We have oxymorphone, which is more potent than morphine. It has fewer adverse effects. It lasts a little bit longer. Morphine tends to last about 3 to 4 hours and causes less vomiting. Oxymorphone is a great drug. I have used it before. The problem with oxymorphone is that it's pretty expensive, so you don't see it a lot in small animal use. You may find it at larger facilities or academic institutions. Now, hydromorphone, on the other hand, is substantially less expensive than oxymorphone, and so you will see a lot of hydromorphone used. Hydromorphone also does not cause this histamine release upon injection. It can cause vomiting, and if you are going to be using hydromorphone, this right here, panting, is extremely common, particularly in dogs. When we give them a dose of hydro, they will sit there and for 15, 20 minutes. They're not hot. It is just the effect of the opiate on the central nervous system. All right, a few others. Methadone. Methadone is actually a pretty darn good opioid pain medication as well. It acts as an NMDA receptor antagonist. in addition to being an opiate agonist. So by itself, methadone then is a little bit of a multimodal analgesic. Methadone is great. It doesn't have a lot of side effects in terms of nausea or histamine release. It is substantially more expensive than morphine or hydromorphone. Now, fentanyl is an incredible opiate medication. You probably recognize fentanyl from pop culture. It is a street drug as well. It is one that is definitely a drug of abuse. It is considered the most potent opioid. Now, here's the thing about fentanyl. It has a very, very rapid onset, but it has an even shorter duration of action. So fentanyl is not a one and done medication. In order for fentanyl to be an effective analgesic, it has to be given in one of two ways, either in a continuous rate infusion, what we call a CRI, or it has to be given via a transdermal patch. And there's a little bit of debate about how well these transdermal patches actually work in animals. I have used them early in my career. I think they worked reasonably well. But some people don't like to use them or dispense them or have a pharmacy fill them because this is a very potent drug of abuse. Now, because fentanyl has to be run in a CRI, the other thing to know about fentanyl is that if you were wanting to use it, and the best place to use this is like in anesthesia or an emergency critical care environment where you have a patient that is not stable, you can give them fentanyl as a CRI to effect. And if there is a problem, like let's say this patient starts going into cardiorespiratory arrest, you can very quickly stop the fentanyl and may not even have to reverse it to get it out of their system. Now, another one is called meperidine. Its trade name is Demerol. It is often given subcutaneously, and it generally is not considered suitable for postoperative pain relief in vet med. Now, on to so those are our pure muse, or most are class 2 controlled substances. Here's our class 3 controlled opioids. Buprenorphine, this is a big one to know. Buprenorphine is a partial agonist. It is extremely common in veterinary medicine. In fact, buprenorphine may be the biggest gun pain medication you find in a lot of clinics. It is longer acting. That is a pro for buprenorphine. It can last up to 6 to 12 hours. However, it is not as good as treating severe pain as the pure mu or the Schedule II controlled substance opiates are. Other positive for buprenorphine. Buprenorphine, even though it is injectable only, it is well absorbed in cats transmucosally. So you can take the same injectable liquid buprenorphine and you can apply it to the gingiva in cats, and it is very well absorbed in cats, not as well in dogs. In general, buprenorphine is best for moderate pain. Buprenorphine, because it is a partial agonist, you can use it for partial reversal of pure mu opioids if you have a crisis and you don't have naloxone. However, butorphanol is better for this if you need it. Now, buprenorphine has become such a popular drug in veterinary medicine that there are 2 longer-acting formulas of buprenorphine that have trade names that are trade products that are available. One is in a subcutaneous injection of buprenorphine called Symbadol, and it is given subcutaneously and it lasts for up to 72 hours. So with one injection, you can get 72 hours of opioid, mild to moderate pain relief. So that's a pretty good thing. Now, also more recently, this drug here called Zorbium has come to the market. Now, Zorbium is a topical, so it's a spot on like some of our flea and tick medications, and it is labeled to last 3 to 4 days in cats. With both of these longer acting formulations of buprenorphine, one thing you absolutely will see in cats is this huge pupils, real stoned looking, and some of these cats act pretty stoned and pretty wonky on these medications as well. Now, Schedule IV opioid, butorphanol. Butorphanol is an agonist-antagonist. What is butorphanol good for? It is actually good for a lot of things. It is a really, really good cough medicine. So it's an antitussive. That means it is a cough suppressant. It is very good as a pre-anesthetic. So it is a drug that we use as a lot of pre-anesthetics. It does have some analgesia, but it also kind of levels out some of the other classes of pre-anesthetic drugs that we use. Butorphanol stimulates kappa receptors while it blocks mu receptors. Thus, it's an agonist-antagonist. Now, it is not a fantastic pain control drug for moderate to severe pain. And it only, in general, lasts about 30 to 60 minutes. You will see in places it is referenced for up to 4 hours. But if you are going to use butorphanol as a standalone pain medication, you need to be prepared to dose it and redose it. Butorphanol is what we use as a pre-anesthetic here at school. We a lot of times will redose the butorphanol after complete anesthetic recovery. Because it doesn't sit around as long, and do that 1 to sometimes 3 times the afternoon of surgery, depending on how painful we assess our patient to be, as well as starting things like gabapentin and carprofen or Rimadyl at that time. Now, Bufen, not used very widely, but just wanted to throw it on the slide to mention it. Now, how do we give these drugs? Post-operatively, our pure Mus only give 1 to 4 hours of analgesia, so we've got to redose those fairly frequently. The adverse effects, as I mentioned before, respiratory depression is the big one. Bradycardia is also possible. And then with things like morphine and hydromorphone, you may see panting. Again, don't misinterpret the panting from the drug as panting secondary to pain. They can be given IM, IV, or sub-Q. Many of these drugs can be run as CRIs or continuous rate infusions. The nice thing about CRIs is they provide very consistent pain relief over longer periods of time. And so you don't have any peak, like you inject a drug, you get a peak, and then the drug is metabolized, and then you get a trough. So you don't have peaks and troughs. You get one consistent level of pain management. So CRIs are optimal for that. When we're using CRIs for pain management, we will typically give a loading dose to get it up to a therapeutic or pain relieving level, and then start that CRI to hopefully hold them at that level. And the other thing about CRIs is that we can often titrate them, so we can increase the volume or decrease the volume that we're giving every hour in order to optimize our analgesic effect. These meds can also be used intra-articular or into the joint. Many times if we do that, we're combining it with a local anesthetic like a lidocaine or a bupivacaine. And sometimes that can provide anywhere from 8 to 12 hours of pain relief. Narcotics and opioids like this can also be used as an epidural, so around the dural mater, or a spinal analgesic or spinal. We've heard the term epidural. You've heard the term epidural as it relates to childbirth. A lot of times in vet med, we use epidurals for orthopedic procedures, so rear limb fractures, forelimb fractures. However, if we are administering epidurals, it's very important that the patient needs to be anesthetized first. Morphine, if used in epidurals, fentanyl is often used in epidurals as well, but morphine, if used, must be preservative-free. So it cannot be the regular morphine that you have in the lockbox. You have got to have a special preservative-free type of morphine to use in epidurals, and that preservative-free morphine is really pricey. Of course, you have to have advanced training in order to perform epidurals. We often will use them at the lumbosacral area in veterinary medicine. However, you can also use them at the coccygeal area to provide anesthesia for things like blocked tomcats. That is a really great anesthetic. Analgesic plan for cats is do a very small coccygeal block to help with not only pain control, but to help with urethral spasm to get them unblocked when it is time to unblock them. Now, epidurals can result in paralysis of the rear limbs, very short term, but they can also promote urine retention as well. But most epidurals last about 6 to 24 hours. Transdermal, as I mentioned earlier, fentanyl patches, as well as the Zorbium topical. Fentanyl patches take 4 to 12 hours to reach therapeutic levels in cats, 12 to 24 hours in dogs. The hair has got to be clipped over the area if we're going to use a fentanyl patch, and we don't want to use it in animals that are febrile because that increased body temperature increases the rate of absorption of the drug. And again, the question marks before absorption is that there is some speculation, like there are people that are pro-fentanyl patch and anti-fentanyl patch. It's not a hill that I'm willing to die on. I have used fentanyl patches in my career and have also prescribed them at different points in my career for chronic pain issues where I didn't have another great option. All right. Moving on, we are going to move on to non-steroidal anti-inflammatory drugs. This is a giant group of drugs that we will use every single day in general practice. What are they good for? They are good for somatic pain, and some of them are good for visceral pain. They are very potent anti-inflammatories in general, and most of our non-steroidal anti-inflammatories are antipyretics, meaning they reduce fevers. How do NSAIDs work? You guys, when you go through and study these things, guys, you need to know NSAIDs inside and out. They are huge drugs in our field. They are huge drugs in human medicine as well. You probably have at least one, if not two or three NSAIDs in your own medicine cabinets. Now, how do these drugs work? They inhibit prostaglandin synthesis. And prostaglandins are chemicals present in all body tissues that are involved in inflammation and mediation of pain following injury. So at the time of tissue injury, prostaglandins are one of the chemical mediators that are released from damaged tissues and that promote pain. Prostaglandins, however, though, let me go back one slide. Please note, there are beneficial prostaglandins and there are not so beneficial prostaglandins. The prostaglandins that are involved with inflammation and pain response, but there are also good prostaglandins. There are prostaglandins that are responsible for maintenance of certain hormone levels. There are prostaglandins that are really important in helping the mucosa layer of your gastrointestinal tract be healthy. So we don't want to, and when possible, block these bad the good prostaglandins that help with homeostasis, but we do want to limit the production of the bad prostaglandins that are resulting in pain and what we call morbidity, not mortality, that's death, but morbidity, which is illness and pain. All right, so non-steroidal anti-inflammatories. Most of them work by inactivating an enzyme called COX, cyclooxygenase, but it is abbreviated COX in a lot of places. COX is involved in synthesizing prostaglandins, and generally there are two forms of COX. There is COX-1, which is present in most all tissues, and there is COX-2, which is present in the central nervous system, the kidney, the reproductive organs, and the eyes. And so most of these COX-2s are the good COX that we want to keep around. And most of the time with COX-2, its production is induced during tissue damage and inflammation. So blocking these pathways of COX means that we're blocking prostaglandins and hopefully promoting analgesia in those situations where prostaglandins lead to inflammation and pain. So here is the clinical pathway of inflammation. I want you to take a good look at it. I want you to have a general understanding of it. We are next semester in that hospital too. We've got an entire lecture on this pathway and we're going to break it down further. But in general, what I want you to note is that here's our cell in the cell membrane. We've got phospholipids in the cell membrane and there is some sort of trauma or toxic event. Those phospholipids of the cell membrane, they are broken down, they get damaged, and those phospholipids get broken down by an enzyme called phospholipase. Phospholipase converts phospholipids to arachidonic acid, and then arachidonic acid is processed by either COX, cyclooxygenase, or lipoxygenase, and cyclooxygenase results in prostaglandin, which is one of our mediators of inflammation. Lipoxygenase produces leukotrienes and other inflammatory mediators. But here's the big take-home message. We've got cell membrane damage. It's broken down to arachidonic acid. Then we have COX pathway and the lipoxygenase pathway. Glucocorticoids or steroids, exogenous steroids that we give, things like dexamethasone, prednisone, those drugs are working to block this enzyme right here, phospholipase. Whereas our non-steroidal anti-inflammatories, NSAIDs, they block right here. They block this cyclooxygenase pathway. So glucocorticoids and non-steroidal anti-inflammatories, they are both inhibitors of inflammation, but they block different parts of the pathway. All right, so selective COX-2 inhibitors. There are those COX, and there are a bunch of nonsteroidals, so it's important that you know a lot of them. The common ones are ketofen, which is used mostly in equine medicine, ibuprofen, which I have in my own desk drawer. We do not want to use ibuprofen in our companion animals or within veterinary medicine. Ibuprofen has a very narrow therapeutic margin or therapeutic index in our companion animals. Even though it's pretty wide in us, it is narrow in our companion animals. So we avoid ibuprofen when at all possible. Now, carprofen or Rimadyl is a drug you've probably heard of. Carprofen is a selective COX-2 inhibitor. There is also a drug called etodolac, which the trade name is Analgesic. We also have daracoxib, which is Daramax. Daramax works, it spares COX-1, so it works only on COX-2. Virocoxib, which is Previcox, again, is COX-1 sparing, is for dogs and horses. Then we have meloxicam. The trade name is Medicam. It is a COX-2 selective. Now, Medicam has a black box warning for cats, meaning that in many cats, it has been shown to be a causative agent of acute kidney failure. Does that mean you cannot use it in cats? No, it does not. It really depends on your vet and what they are comfortable with. I don't use anything as an emergency practitioner for a species that has a black box warning. So I do use meloxicam in dogs. We use a lot of meloxicam in exotics as well, but I don't prescribe it to cats because I have something else that I can prescribe to cats that is safer and specifically labeled for them without a black box warning, and that is Onsior or robenacoxib, and that's what we're going to use here in school for our cats as well. It's COX-1 sparing, highly COX-2 selective, and it is approved by the FDA in the United States for a 3-day course. Next up, other NSAIDs. Dimethyl sulfoxide. This is a weird one, and it's one that you probably are not going to see if you're in small animal, but they do use a lot of it in large animal. And it is a topical medication that is abbreviated often DMSO. Now, DMSO is a carrier nonsteroidal, and so it is often mixed with something else and applied topically. They use it in horse medicine, equine medicine a lot as like poultices. They'll put DMSO in it to help pull a molecule into the circulation or into the tissues. How well does it work? I don't really know. It is in one product that is a small animal product called Synodic, which is a topical steroid anti-inflammatory with this DMSO product in it. And I will tell you, I like that product. I've used it before. All right, acetaminophen. Acetaminophen's trade name is Tylenol. You probably have it in your counter. You must know this. Cats cannot have acetaminophen. No, 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 no. It will cause methemoglobinemia, which results in cyanosis and severe liver toxicity. Cats that get acetaminophen accidentally, there is an antidote for it, but you have to recognize that it happened pretty quickly and you have to have it on hand, and not a lot of places have it on hand, but that antidote is called acetylcysteine. A lot of veterinary emergency practices do carry acetylcysteine. 24-hour practices do. I don't know about nights and weekends, but 24 hours do. There's this nonsteroidal called Buscopan compositum for equine colic, and there is this newer NSAID called Galliprant, and the drug name is actually Grapaprant. And it has a unique kind of mechanism of action. It is non-COX inhibiting antagonist of prostaglandin receptors. So when this drug came to market about 8 years ago, it was marketed as being potentially safer than our traditional Daramax, Previcox, Carprofen. There are a handful of other things that are used. Some of you may have seen Adequan, which is a polysulfated glycosaminoglycan. That is an injection that the goal of which is to help rebuild cartilage and joints. And then there is this hyaluronate sodium product that is used for equine synovitis. There is an ongoing issue with one of the medications very much like this that is used frequently in equine medicine. Their manufacturer had a contaminant in their product, and it was a widely distributed product, and it was used intra-articular in a lot of horses. And these horses, they're still trying to figure out exactly what the problem is, but horses that were getting these injections, these performance horses, these athletic horses that are getting these injections to try to help improve performance and preserve the health of their joints, started becoming critically ill and turning septic. Right now, it's looking like it may be a fungus that is causing this, but this is an ongoing issue, a current event issue in veterinary medicine. All right, as you can probably tell, all nonsteroidals do not work in identical ways. Acetaminophen and ketorolac work mainly on prostaglandins in the brain. Therefore, they are called centrally acting. Some nonsteroidals are selective in blocking only one of the two enzymes in peripheral tissues, the COX-1 versus COX-2. Some NSAIDs appear to work in both locations. They work on COX-1 and COX-2, or they work on the COX pathway and the leukotriene pathway as well. All right, in general, important to know, NSAIDs are generally metabolized in the liver, excreted by the kidneys or the liver. There are giant species variations in terms of how long nonsteroidals last per species. For example, aspirin, common over-the-counter product. Aspirin has a 38-hour half-life in cats because cats don't have this glucuronyltransferase enzyme in their liver. So if you give them a dose of aspirin, you need not give them another dose probably for at least 48 hours, if not 72 hours. But in dogs, it has an 8-hour half-life. And then if you're a horse, aspirin only hangs around, the half-life of aspirin is only an hour in horses. So different species are very different. Toxicity levels as well. As I mentioned in a couple slides ago, Tylenol or acetaminophen will kill a cat, but it's a relatively safe drug at the right dose. It's a relatively safe drug in dogs. Now, ibuprofen and naproxen, which is a Aleve, they're great for you and me, but they are highly toxic to dogs and cats. I have seen a 100-pound Great Dane killed by 2 tablets of Aleve from a bleeding GI ulcer. Just don't do it. They are not controlled drugs. They are not sedative medications, and they are generally effective orally. Now, adverse effects. These are also important to know. Again, these nonsteroidals as analgesics are critically important drugs for you guys to understand and have good working knowledge on. Prostaglandins, as I mentioned a while back, are important for homeostasis in a lot of organ systems. And the adverse effects that we see from nonsteroidal anti-inflammatories come from blocking the beneficial effects of prostaglandins. So I mentioned that some prostaglandins are very important for the mucosal layer of gastrointestinal tract. Therefore, if we block the prostacyclin, the beneficial prostaglandin in the stomach, with nonsteroidal drugs, it then can lead to GI ulcers. Those ulcers can then hemorrhage or perforate, and that can be fatal. So a lot of times if we are having to give these drugs in dogs or cats that have known GI upset, it can be beneficial to add some GI protectant medications like sucralfate or H2 histamine blocker with these drugs. Not perfect, but it may help. Now, renal side effects. Here's the other big one. Kidney. Prostaglandin E2 maintains renal blood flow. Remember how much of the cardiovascular flow those kidneys want to have, 25% of it. So prostaglandin, is really important to help maintain that kidney blood flow. So we want to be exquisitely careful when we use nonsteroidals about knowing whether or not that patient has healthy kidneys, because we are going to reduce blood flow to the kidneys by giving them nonsteroidals. And if they have pre-existing kidney disease, that is a bad thing. Now, also, if they are hypotensive, their kidneys are already struggling to keep up. If they are dehydrating, they're already struggling to keep up. Or if we are anesthetizing them. Remember when I said that all of our anesthetic drugs have the potential to cause profound hypotension. So if we give nonsteroidal drugs and then we give anesthesia, we have the potential to cause an even larger insult at the level of the kidneys. So unless there are IV fluids running and you're monitoring blood pressure during surgery, it is generally best to wait until full anesthetic recovery. For the same reasons, it is generally best to not give these drugs to acute trauma patients, those that may be going into shock or hypotensive. We don't want to use NSAIDs with shocky patients or animals that have been recently traumatized. We need to make sure they're stable, they're hydrated, their kidneys are functioning well, and then utilize them. Now, what else do these nonsteroidals do? Number one, they interfere with primary hemostasis. Specifically, they interfere with platelet aggregation. This is why they want you as humans, before you have any type of surgery, to discontinue taking things like aspirin or ibuprofen for many, many days before your surgery, because these drugs work to inhibit platelet aggregation. So your clotting is not going to be as effective when you have taken a nonsteroidal anti-inflammatory drug and then you have bleeding. Also possible is liver damage. So generally we do like to screen liver and kidneys on our patients before prescribing these drugs. Next up. All right. I think we're almost there, guys, ish. All right. Adverse effects. Minimize use for trauma patients. Minimize use for GI surgeries. Don't use in patients that have coagulopathies. And really, really important in vet med, even though they do this in people, is we do not want to combine these drugs with steroids ever. We will absolutely exacerbate adverse effects with those. All right, handful of other drugs that are used as pain control agents. The alpha-2 adrenergics. What are some of these? If you go back to your pre-anesthetic lecture, you'll find them. Ketamine, also mentioned in pre-anesthetics, is an NMDA receptor antagonist. Tramadol is an over-the-counter, or it's not over-the-counter, pardon me, it's a controlled substance, but it's an oral weak mu agonist, and it does also inhibit serotonin and norepinephrine reuptake. Miscellaneous agents that we'll use: lidocaine, amantadine, which is a drug that blocks NMDA as well and is used a lot for wind-up pain. Gabapentin is often used for neuropathic pain. Some tricyclic antidepressants may enhance the effect of opiates. Some benzodiazepines may be pain relievers in birds adjunctively. Remember, they're not pain medications in our other companion animals, but in birds they may be adjunctive. And then there's something called EMLA cream, which is a topical lidocaine cream. All right. Few others. Skeletal muscle relaxants can be used to help acute inflammation and trauma in muscle spasms. The one that you need to know is called methocarbamol, and methocarbamol trade name is Robaxin. It comes in an injectable form and in an oral formulation. The other one that gets used, dantrolene, may be used in large animals. Guaifenesin, as we mentioned in the pre-anesthetic medication article, is used in large animals as a muscle relaxant. We don't use it in small animal as a muscle relaxant. Guaifenesin, we use it as a mucolytic expectorant agent. But not as a skeletal muscle relaxant. But methocarbamol is the big one for small animals. All right, corticosteroids. They are used to treat inflammation, pruritus, itching, and immune-mediated diseases. Also used to treat shock is what your book says. That's a no. We don't use it to treat shock. Don't do it. Laminitis in horses, anorexia, adrenal insufficiency, and various other conditions. Corticosteroids, unlike nonsteroidals, corticosteroids are naturally occurring in the body. So our body typically controls the release of steroids in our body by two mechanisms, and those occur in the adrenal cortex. And so we've got the feedback loops. Remember, ACTH goes to the adrenal glands to release cortisol. Is also uploaded, that adrenal cortex production is increased during times of physiologic or emotional stress. All right, so here's the brain, here's the kidney, here's our adrenal gland sitting on top of the kidney. The adrenal cortex is the outside part of it. The hypothalamus affects the pituitary gland to produce ACTH. Stress and anxiety can also affect the pituitary gland, and corticotropic releasing factor can then work on the pituitary to produce adrenocorticotropic hormone, which then tells the adrenal cortex to produce cortisol. That cortisol goes to the target organ to stop inflammation, but it also plays back up to the brain to hopefully slow, as a feedback loop, to slow production down when it is in excess. This is called the hypothalamic pituitary adrenal axis. All right. One of the major indications for clinical use of corticosteroids is their anti-inflammatory effects. They do also protect cells from inflammatory trauma, such as in immune-mediated conditions. So conditions where the body starts attacking itself, like IMHA, ITP. We use steroids for this. We also use steroids for treatment of lymphoid tumors. Remember, our B cells, our T cells, they are suppressed by steroids. So sometimes when we have tumors of the lymphatic system, corticosteroids are often used as a component of chemotherapy for many of these types of cancers. They come in all varieties, injectable, oral, topical, you name it, we've got it. All right, back to clinical pathway of inflammation. Thing to note is that glucocorticoids block here. They block this enzyme that breaks down the phospholipids of cell membranes. All right, local, regional, and topical anesthetic agents. Many situations, we just need a little bit of anesthesia to prevent pain or to be able to achieve something. Here is what I want you to understand about local anesthetics. They work by preventing generation and conduction of nerve impulses in peripheral nerves. They block the sodium channels of the nerve. Then the impulse cannot be transmitted up that nerve to the spinal cord. So we do this by infiltrating areas with a local anesthetic. We can do it with epidurals. We can apply topical anesthetics. We can specifically block nerves themselves. And one other thing that these topical anesthetics are good for, because they block sodium channels, is they have potential to be used as antiarrhythmics. And we'll talk much more about those in our cardiac medications lecture. All right, just a couple in diagrams of technique. This is demonstrating an epidural. So we've got skin, we've got our epidural needle going in between the vertebrae into the epidural space here. So here's the dura, here's the spinal cord. The black is central cerebrospinous fluid. Our discs are down here. So we're going between the facets, poking a hole in the dura and injecting our local anesthetic here. We do this in cows right at this level. In cows for standing C-section or an LDA surgery, we'll often do line blocks. You can do these in small animals as well along the linea, but we'll infiltrate the muscle and the tissue and the subcu tissues and skin with a local anesthetic to allow us to make an incision. In cats, if we are doing things like declaws or a toe amputation, hopefully most of you don't get to experience a lot of declaws. I've done them in my career. They are quickly being phased out across the country, especially in the last decade or so. But you can do specific nerve blocks to help deaden the nerves that go to the digits if you were doing a toe amputation. Horses in equine medicine use blocks all the time for lameness workups to help determine where the lameness is occurring, at which joint is the problem. Oh, had a blank one in there. How nice. All right. Cows, useful to administer a regional nerve block to prevent straining if you're trying to replace a prolapsed uterus. Local anesthetics are available in tons of forms. There is a long-acting veterinary labeled bupivacaine called Nocita that is supposed to last for 48 to 72 hours if you infuse it. at the site of your injection, whereas something like lidocaine is only going to last for 2 to 3 hours typically. Topical one is called proparacaine. And then there are a number of VT&E prep questions that deal with other modalities to treat pain, and they are called physical modalities. And those are light, like red light therapy, heat, sound or ultrasound waves, and water or hydrotherapy. 2015 is the most recent AHA, combined with the American Association of Feline Practitioners, or AAFP. They put out guidelines every decade or so, and they update them. They are evidence-based. They are there to support us as veterinary professionals in trying to incorporate best practices into improvement of patient care. Other physical modalities: cold, heat, massage, acupuncture, hydrotherapy, and a handful of some random pain stuff from the VT&E review. There is something called a myofascial trigger point, which is where a painful strained muscle contraction can't easily self-release, or basically a knot in the muscle. I know you and I can verbalize those a lot better than our patients can. Vet techs, VT&E review likens you most to neonatal pediatric nurses in terms of pain assessment. Dysphoria. So some animals receiving these pain meds may end up in a state called dysphoria, meaning that we're not doing a great job of treating pain, but the animal seems stoned out of their mind and they are basically unconsolable. So the difference between a painful animal and a dysphoric animal is likely in a dysphoric animal's inability to respond appropriately to soothing interactions, whereas most painful animals will. Osteoarthritis in cats can be demonstrated most commonly by decreased jumping. We have underestimated pain in cats for years, guys. We're just starting to get on board with really being more aggressive with aging cats and their pain. Also important to note that a low pain scale score does not necessarily indicate that an animal is pain-free. As I mentioned, they may be very stoic. Chronic pain patients need to be assessed every 3 months minimum if you are in general practice. That is the best recommended interval as far as pain scale scoring for chronic pain. All right, some other random stuff. Preemptive scoring systems are subjective based on expected degree of discomfort from a procedure. Acupuncture is a no-no if you have a pregnant animal. It's a no-no if you have a septic animal. And for obvious reasons, it's a no-no if you have bleeding disorders. Capsaicin, a lot of over-the-counter products for you and I have capsaicin in them. What is it? It is actually a derivative of a chili pepper that's added to a lot of topical formulations. And then cold therapy works at the level of nociceptors. When you are using ice or cold therapy, please note that if the skin turns white after 20 minutes, you may have damaged the tissue. So skin should be red. So white with cold can indicate tissue damage. And heat is best for chronic pain. Woo, that's a long one. Hopefully it's somewhat intelligible, and hope you had a good weekend. And any questions, please feel free to ask me in class, and I'll talk to you guys later.